Hello, my name is David Back from the University of Liverpool, and in this talk we're going to focus our attention specifically on drug absorption. If you viewed the first talk in the series, then we outlined some of the aspects of drug absorption, and now we're going to go into this in much more detail. So we have some specific objectives. Number one is to understand how drugs are absorbed, specifically following oral absorption. And then to recognize that there are important factors which can alter absorption and therefore the bioavailability of a drug. And thirdly, to show that these changes in pharmacokinetics may be really of clinical relevance. So let's think about oral drug absorption. There are certain factors about the drug itself which we have to take into consideration. So disintegration of the dosage form, a tablet or a capsule, it has to disintegrate, and that can occur in the stomach and in the upper part of the gastrointestinal tract. And then the dissolution of the particles of the tablet or the capsule. And then we have to ask the question, how stable is the drug itself, the active ingredient in the gastrointestinal tract? And then there are physiological factors, the gastric emptying time, the motility of the gastrointestinal tract, the presence of food, the type of food that has been eaten with the drug, the passage of drug across the gastrointestinal wall and blood flow to the gastrointestinal tract. These are all physiological factors which, together with the drug factors, will determine how much of the drug is absorbed from the gastrointestinal tract. So let's look at oral drug absorption again from a diagrammatic perspective. 100% of the drug goes into the stomach, and then within the stomach those blue particles are the tablet, the capsule disintegrating, and the drug goes into the upper part of the gastrointestinal tract. So if we look at those blue particles, they then pass through the wall of the intestine, but note that there are some green particles as well, and that is because the drug may start to be metabolized already in the wall of the intestine, and then the drug can be excreted back into the lumen of the gastrointestinal tract. The blue particles, then active drug, can hit the portal circulation and go through the liver, and we discussed that a little in the first talk before you get the drug in the systemic circulation, which is the bioavailability and the availability of the drug for the general circulation. So these are the general principles that we have to think about. So how's a drug absorbed? Some drugs are absorbed passively by passive diffusion, others by carrier-mediated transport. And you can have facilitated diffusion, that's down a concentration gradient, but by protein-directed transport, facilitated diffusion. And others are actively transported with an energy source and against a concentration gradient. So let's think about what factors can affect our drug being absorbed. We have to think about those physiological variables. So the center column of this table talks about gastric emptying, gastric motility, gastric acidity, as well as the enzyme activity and transporter activity in the wall of the enterocyte. So how much drug is absorbed and how fast it's absorbed, the rate and extent, will be governed by some of these physiological variables, which in turn can be affected by a number of factors. And I've listed some of those factors: the presence of food, the presence of other drugs, disease, for example. So let's look at one of those things, which is a common thing. Do we take a drug with food or without food? Is that important or is it not important? Well, actually it can be quite important, because food can decrease the gastric emptying rate and delay absorption. You can also bind the drug to food, so you can have binding of the drug to food components, which can decrease absorption. But on the other hand, for a poorly soluble drug, actually food can increase the solubilization of the drug and increase the absorption. So it can be quite a complex relationship. Should I take a drug with food or without food? So here's some examples of drugs which we use for hepatitis C, the direct-acting antivirals. Notice that sofosbuvir ledipasvir, one tablet, it says you can take it with or without food. But the complex paritaprevir, bidosvir, ritonavir, dasabuvir, that has to be taken with food. And here you've got 4 tablets taken once a day or twice a day with the dasabuvir, and you're taking that with food. So the implications of that is that we have to really adhere to whether we're taking the drug with or without food, and follow the recommendations for the individual drugs. But we can also think about how other drugs, many patients are taking not just a single drug, they're taking multiple drugs for different comorbidities. And other drugs can affect the drug of interest that we're specifically thinking about. That's a factor which can affect the variable which will influence the absorption of the drug. So here's one example, antacids. You can go to the chemist and over the counter you can buy certain antacids. These can be normally aluminium, magnesium containing antacids, and they will neutralize the acid in the stomach to some extent. But there are other drugs which are more potent, such as the H2 receptor antagonists and the proton pump inhibitors. They block acid release from the parietal cells. So we do have these aspects of having to understand the role of antacids in the absorption of drugs. So let's think about the different types of antacids. Antacids over the counter, you have to take them every 4 to 6 hours to neutralize the acid, and they've got limited efficacy. H2 receptor antagonists, cimetidine, famotidine, for example, these give competitive blockade, but actually you overcome the release in a relatively short period of time. So they're not long-acting drugs. They're effective, but not particularly long-acting. Whereas the proton pump inhibitors, the PPIs, such as omeprazole and lansoprazole, they are the most effective, giving a sustained pH control because they bind strongly, covalently to the specific enzyme ATPase. And again, within the class of PPIs, you've got different lengths of how long they will work for, and omeprazole will be longer acting, for example, than lansoprazole. So these are important drugs. So thinking about the HCV drugs, is this important? Well, it is important. So for lidiposphere, the presence of antacids or H2 antagonists or proton pump inhibitors can reduce the absorption, and there are specific instructions, and we'll deal with this particularly in a later talk around the detailed examination of how should we take those drugs. Velpatasvir is the same, and just the recently approved drug in 2017, glecaprevir, that's also got potentially reduced absorption with proton pump inhibitors and H2 antagonists. Let's focus our attention now on the shuttle pumps, the intestinal transporters in the gut. These are like little buses which pick up people and take people from A to B. So these shuttle pumps are proteins which take the drug from A to B. So they're taking the drug across the intestinal wall. And we have influx transporters. So at the top there you can see OATP, an influx transporter, which takes drug across the enterocyte. But we've also got efflux transporters which want to do everything to stop drug getting into the bloodstream. So they're preventing the drug, in a sense, being absorbed because they're picking up the drug as it's transported and throwing it back into the lumen of the gut. So these transporters are really important for us to consider. So as we look at the lumen in a different type of diagram, you've got this protein, P-glycoprotein, PGP. It's a really important efflux transporter, trying to stop the drug being absorbed. But as drug is absorbed across the enterocyte, there's an enzyme waiting for it to try to break it down and push it back out into the bloodstream. So we've got these two processes of transport and metabolism, which are both trying to, in a sense, stop the drug being absorbed, and we have to think about that. And if you upregulate those proteins or inhibit those proteins, then it can affect how much drug is going to be absorbed. So enzyme induction and enzyme inhibition can have an effect on the extent of the drug absorption. So here are some of these inducing drugs which can induce the enzyme cytochrome P453A, for example. So in the strong inducer, we have the anti-epileptic carbamazepine, phenytoin, the anti-TB drug rifampicin, and commonly many people use St. John's wort, which you can buy from the chemist. It's a really strong inducer and it can affect the co-medications that a patient's taking. Then we have some moderate inducers and weak inducers, and also inhibitors, which will have the opposite effect of the inducer, and that is they will inhibit these proteins. So there's a list of drugs, grapefruit juice, for example. So if anyone is on an antihypertensive such as amlodipine, it will say on the label, do not take grapefruit juice or grapefruit with your blood pressure tablets. So that's just a common example of something that can inhibit, and grapefruit juice is really important. Other examples of strong inhibitors, moderate inhibitors, and weak inhibitors. These are just examples which can be found on the FDA website. And these are some of the important P-glycoprotein inducers and inhibitors. Some of the same clearly inhibitors, clarithromycin, itraconazole, and ritonavir. And we're going to expand on this as we specifically focus on individual drug-drug interactions for the HCV drugs as we develop this course. So in summary, I hope I've shown you that the rate and extent of drug absorption is dependent on the drug itself. What kind of drug are we taking? Its physical chemical properties, but also on the physiological features of the individual patient. And our knowledge of this process of drug absorption is really a key to understanding how we take our drugs. So if the doctor is saying you must take it with food, there's a reason. If it says separate from food, there's a reason. And we need to understand that that is important to maximize the benefit of taking the drug. And a more detailed outline of drug absorption interaction specifically will be presented by Professor David Berger in session number 6.